section. If we can have Dr. Fan come up to the podium. Okay. So the first talk is titled, A Study Analyzing Macular Microvascular Features Before and After Vitrectomy Using OCT Angiography in Patients with Idiopathic Epiretinal Membrane.
Good afternoon, everyone. My name is Phan Thị Tú Cúc, and I work at Ho Chi Minh City Eyes Hospital in Vietnam. Today, I will presenting our research on macular microvasculature feature before and after vitrectomy using OCTA in patients with idiopathic epiretinal membrane. I would like to note that we have no financial disclosure related to this study. As we know, idiopathic retinal membrane is a common condition characterized by fibrocellular proliferation over the ILM. The traction on the inner retina can alter its morphology and hemodynamic, leading to visual acuity loss and metamorphosia. Vitrectomy with ERM building is considered the gold standard. However, visual recovery may remain incomplete for some patients, highlighting the importance of understanding predictive factors for outcome. According to two studies conducted in Vietnam in 2016 and 2017, clinical and OCT factors such as duration of symptom, reoperator visual acuity, membrane morphology, and ISOS disruption were identified as predictors of poor visual improvement. Although many authors worldwide from 2018 to present have identified additional predictors by OCT, such as EIFL-3, a proportion of patients continue to experience visual impairment. OCTA is a non-invasive imaging technique that enables detailed analysis of the retinal and choroidal vasculature. It provides valuable insight into the morphology of FAZ and vascular density, which are key elements for understanding the pathophysiology of IERM and its impact on visual outcome. IERM is a significant concern in Vietnam, and recent studies have highlighted that change in macular microvasculature of IERM patients can assess using OCTA. This advancement allows us to closely examine this trend, offering a deeper understanding of the condition. Our study had two main objectives: to describe the macular microvasculature change in IERM eyes before and after vitrectomy, and to identify the correlation between the macular vascular change, EIFL classification, and post-op visual acuity. We conducted a prospective study from April to October 2022 on 40 patients. The patients were classified into non-EIFL and EIFL group, and OCTA was used to measure parameters like FVD, BFVD, and FAZ area. The inclusion and exclusion criteria, as I mentioned there, and the definition EIFL and OCTA parameters, as I mentioned there too. Compared to healthy eyes, IERM shows higher FVD and BFVD, as well as a smaller FAZ area. This can be explained by the EIFL centripetal traction leads to the displacement for inner retinal layers toward the fovea center. The FAZ area was smaller pre-op, and at post-op 1 month, it saw a slight decrease. By 2 to 3 months post-op, the FAZ area gradually expanded. In contrast, FVD and BFVD were significantly higher pre-op and saw a progressive decrease. This can be explained by IERM adhere moderately to ILM. However, the ILM adhere much stronger to the underlying retina, so the centripetal building of the ILM may limit improve in the FAZ area observed after surgery. And the EIFL group consistently show a smaller FAZ area and higher FVD and BFVD compared to the non-EIFL group or over time. This can be explained by the chronic EIFL contribute to a slower recovery of microvasculature. PCVA at post-op 3 months were higher compared to pre-op, both within the EIFL classification and overall. Additional BCVA in the non-EIFL group were consistent higher than the EIFL group at every time point assessed. FAS area saw a positive correlation with BCVA at 3 months, indicating that larger FAS area is associated with better visual acuity. A strong negative correlation between EIFL classification with BCVA at post-op 3 months, emphasizing that present EIFL is a significant predictor of worse visual recovery. Conclusion, vitrectomy with ERM peeling led to partial restore of macular microvasculature. Using OCTI matrix and EIFL classification have evaluated disease severity, guide surgical resistance, and predict recovery trends. The presence of EIFL indicate worse post-operative outcome. Non-EIFL case may benefit from early surgical intervention for better recovery. Thank you for your attention.
We have time for one question. Okay, thank you.
Okay, I think next up we have Dr. Mark, right, the co-chair, who will be presenting on OCT split spectrum amplitude decorrelation with optoretinography in inherited retinal degenerations.
Thank you. I'm Mark Panisi, and I am from the Retina Foundation in Dallas, Texas, and also the KCI Institute in Portland, Oregon. I'm going to be talking about a new outcome measure that we've been developing called optoretinography. And I'd like to acknowledge my colleagues, Siyu Chen, and many of my fellows who helped with this project. So what is optoretinography? Well, you're all probably familiar with the ERG, which measures the electrical response of the retina to light. The ORG actually measures the optical response of the retina. And you can see here that if we do adaptive optics imaging and stimulate the retina with light, you can actually see changes in the brightness of the individual photoreceptors. And this results from a change in the properties of the photoreceptor when light hits the outer segment. So when light hits the outer segment, there's a transient shortening of the outer segment, followed by an elongation, and then a return to baseline. And we can actually measure these changes in both healthy and diseased retina. And as photoreceptors become sick, such as in a retinal degeneration, this response will decrease. And this shows the changes in the length of the outer segment in response to light using adaptive optics in a number of different patients with RP. Now, adaptive optics is a very specialized technique and requires very expensive equipment and expertise. So we've tried to develop a way to measure the ORG just using the OCT. And this is something called split spectrum amplitude decorrelation optoretinography. And the idea is that you can measure the wavefront of the light going into the retina and then the light that is reflected. And these two waveforms will interact to create an interference pattern. You can then measure the same measurement after a flash of light, and you'll get a different interference pattern. And you can then look at how these are decorrelated with each other. And so we stimulate the retina with alternating bands of light. We isolate the outer segments from the OCT. And you can see here, we can actually generate an optical image that is showing the change of these photoreceptors. We can show that as you increase the brightness of light, the signal increases in a predictable manner. And so this is our basic protocol. We use 3 different bands, 3 by 1 millimeters, and we combine these together. And this is essentially what a normal response will look like from a retina. So this is totally non-invasive using OCT. For our study, we looked at 39 patients with inherited retinal degenerations, mostly retinitis pigmentosa, but also those with cone dysfunction. This shows an example of a mild patient with a form of sector retinitis pigmentosa, and you can see that the fovea actually looks quite normal, and the ORG signal looks quite normal. Here's a more advanced patient where you can see loss of the outer retina and constriction of the ellipsoid zone. And here you see that the ORG is quite decreased, and it actually correlates quite well with microperimetry. Here's a second example showing a similar response. And we have shown that this technique is repeatable, both in healthy patients and patients with disease. We've also shown that the signal measured by ORG correlates with microperimetry. This shows an example of where this might be useful. This is a very mild case of a patient with Stargardt disease. As you can see here, there's just a very subtle change on the microperimetry. But when we measure the ORG signal, we actually see quite a dramatic reduction outside of the fovea. So it does look like ORG can be more sensitive than microperimetry, and it's completely objective, unlike microperimetry, which relies on the patient's response. So if we look at patients with rod cone dystrophies versus those with cone dystrophies, we see that the patient with a cone dystrophy is actually affected more. So this particular technique might be useful for picking up early disease in cone photoreceptors. So in conclusion, we have shown an objective and reliable measurement of photoreceptor function in both normal patients and those with IRDs. This correlates well with microperimetry and may detect early cone function loss even before microperimetry. Thank you very much.
All right, thank you, Mark. Is there any questions for? Oh, right. Yeah, can go to the mic.
Very nice presentation. Is there any role of autofluorescence while you're seeing the cone rod dystrophy apart from octa or microperimetry?
Mm-hmm. Yeah, we haven't specifically examined autofluorescence in relation to the ORG, but I do suspect that it's going to correlate because, as you know, many patients with inherited retinal degenerations will have this hyper autofluorescent ring right at the transition zone, and that's probably also going to correlate with the ORG function.
Okay, great. Thank you.
Mm-hmm. Thank you.
Thank you. So next we have Dr. Su Wen Ding. She's not here, so it's a video. Okay, all right. Then next we have Priyanka Gupta, who will be presenting on clinical breakthroughs with ultrasound, biomicroscopy, tackling 4 challenges, challenging ocular cases. Right.
Yeah. Good afternoon, everyone. So I'll be speaking on clinical breakthroughs with UBM, tackling 4 challenging ocular cases. Myself, Dr. Priyanka Gupta. It's not moving. Yeah, thank you. So the non-invasive visualization of living tissue at the microscopic level is a long-cherished dream in the field of medicine and biology. However, the conventional methods are limited to certain millimeters. So here come another biomicroscopy, which is UBM, which provides high-resolution imaging of ocular structures present anterior to the pars plana region, which are difficult to evaluate with conventional imaging methods. So the purpose of the study was to elucidate the ancillary role of UBM in diagnosing challenging cases. We took into account 4 cases where demographic details, clinical examinations, slit-lamp photography, wide-field color photograph, ultrasound, anterior segment OCT, wherever needed was done. UBM done in all the cases to delineate the pathology, to see the extent of lesion and the depth of lesion. So coming straight forward to the case 1, interestingly, this 10-year-old female came for opinion regarding right eye staphylomas diagnosed elsewhere. Vision in the right eye was 6-6 part. If you see the slit lamp photo, there is a subconch lobulated mass present superiorly and nasally, overhanging on the limbus. Fundus examination was normal. So we did the AIOS2025, which shows the last cyst present superior nasal quadrant with query communicating with the anterior chamber. However, the depth of lesion could not be elucidated. So we did the ultrasound, and ultrasound showed this well-defined hyperreflective walls with a hypoechogenic cyst measuring almost like 13 into 6 millimeter in size, extending superior nasal to 3 o'clock with no communication in the anterior chamber, and mild scleral thinning was noted. However, there was no involvement of ciliary body. So here UBM has painted the clear picture of the patient. So finally, the patient underwent concept excision with scleral graft, and the biopsy showed no goblet cells, only stratified non-cretinizing layer was being lined. Immunochemistry shows CK3 and CK19. So finally, the diagnosis of scleral cyst was being made. So this is post-op day third slit lamp photo, which is showing a well-placed graft. Cornea is clear, conch is well opposed, and the UBM is showing the well-placed integrated graft, and vision was maintained at 6.6. Coming to the another cyst story of 6-year-old female, came for opinion for bleb-like lesion in the left eye. On slit lamp examination, the left eye showed conch cyst seen inferior nasal quadrant encroaching on the cornea extending from 6 to 9 o'clock position. Anterior segment OCT did not give much of clue. Only thing we thought it's a multiloculated conch cyst. So we did the UBM, and UBM showed this, as the video is also showing, well-defined subconch cyst overlying the limbal area with no communication in the anterior chamber and no involvement of the underlying intraocular structures. So finally, the patient underwent cyst excision with conch advancement with scleral patch graft, and the biopsy showed no goblet cells, and we made a diagnosis of scleral cyst. And if you see the post-op slit lamp photo, there's a well-placed graft, and vision is maintaining 6.6. Coming to the case 3, very interesting hypotony story. A 60-year-old male came with a complaint of diminution of vision in the right eye for last 2 months, vision in the right eye with finger counting close to face. The past history was important because he underwent retinal detachment is surgery with oil in C2, and IOP recorded was like 5. And this color photo is very quite hazy, and the OCT, if you see, it's a choroidal folds and recurrent retinal detachment. So in view of low IOP, we did the UBM. UBM did show the presence of hyperreflective membrane, which is anteriorly extending towards ciliary body and posteriorly till past plana, and the diagnocyclitic membrane and the blunted ciliary process was being made. So the patient underwent surgery, which is a combined surgery with vitrectomy, re-vitrectomy, re-oil, and the membrane peeling was being done. And this is post-op at 2 months. So vision is 636, retina is well attached, IOP has rose to 10. Coming to the clinical case 4, a 55-year-old female complained of diminution of vision, pain both eye for 1 week, vision right eye 4/60, left eye 6/60, IOP right eye 25, left eye 14, on slit lamp there were cells, fundus normal, systemic history, recently diagnosed migraine. So this is slit lamp photo, very beautifully captured the AC cells, and the second image showing the shallow anterior chamber. The past history was important because the patient was on anti-glaucoma medication, and the IOP was being raised at 40 and 25. They were diagnosed as close-angle glaucoma and advised YAGPI in both eyes. Ultrasound was normal. We thought of doing the UBM, and UBM did show the presence of ciliary effusion with a positional angle closure and mild anterior rotation of ciliary body. We tried to see the big picture, inquired for systemic medication. She was on topiramate 25 milligram once a day, and this was a case of topiramate-induced secondary angle glaucoma. We asked the patient to stop, and the patient stopped, and look at the miracle. There's a resolution of ciliary effusion, opening of angles. The vision is improved, and IOP is being normal. So basically, it's an idiosyncratic reaction of a drug which was causing the ciliary effusion. So to conclude, there were the 4 different presentations related to complex diagnostic dilemma where the UBM has really made the difference. Literature has given some beautiful review articles on the UBM, but still I would say that UBM is underutilized. However, it is superior to AIOS-OCT in studying the ciliary body, delineating the extent and depth of scleral cyst. So to conclude, UBM provide crucial in establishing the correct diagnostic and formulating the effective treatment plan, and also giving detailed additional anatomical information. Thank you so much.
All right, we have time for questions. All right, thank you very much.
Thank you so much.
All right, our next talk is titled Retina Heart Axis Insight from Retinal OCTA Imaging Cohort, Dr. Xiu Zhu. No? Okay. We'll go on to the next talk. Do we have Dr. Zhang here? No? Okay. Dr. Stopra? Perfect. So the talk is titled accuracy of 7 artificial intelligence-based intraocular lens power calculation formulas in medium-long eyes, a 2-center study.
Honorable Presidium, dear colleagues, it's a great honor for me to speak here. My financial disclosures. Ernest Hemingway, an American writer and Nobel Prize winner, used to say,
Is the mic on?
Hold the microphone down a little bit.
Okay.
to write an article on Chinese dialectics, you must first read the articles on China, then the articles on dialectics, and next combine them. So thinking like Hemingway, first a few words about AI-based intraocular lens power calculation formula. Here is its flow chart. Since in 1967, Sviatoslav Fyodorov published first theoretical intraocular lens power calculation formula, many others have been developed over the years. Traditionally, they are classified by generations. However, Douglas Koch in 2017 proposed another classification based on a logical approach. We can distinguish formulas based on data-driven, optical approach, and hybrids. Last year, Giacomo Savini updated Koch's classification, expanding AI segment. In addition to pure AI formulas and hybrids, we can distinguish also universal AI algorithms, which can refine accuracy of existing formulas. Different variables are used to as input data in AI formulas, and almost each of these formula has its own online calculator. Kenneth Hofer was probably the first who used the term medium-long eyes. To follow him, many others applied it. Some authors consider 24.5 millimeters as a lower limit of axial length in long eyes. Some 25.0, some 25.5 millimeters, and some 26.0. And this range from 24.5 to 26 millimeters is called medium-long eyes. So the aim of our study was to compare accuracy of 7 artificial intelligence-based intraocular lens power calculation formulas in medium-long eyes. It was international 2-center study. We used 214 eyes of 214 patients with medium-long eyes. We applied rigorous exclusion criteria such intraoperative or postoperative complications, previous eye surgery or corneal diseases, postoperative BCVA less than 0.8, and corneal astigmatis greater than 2.0 dioptry. Preoperatively, input biometry was taken with IOL master. The power of implanted IOL was randomly selected from the outcomes of SRKT, Halliday 2, or Barrett Universal. 3 months after phacoemulsification, refraction was measured, and postoperatively, IOL power calculation were performed using HIL-RBF, KN per DGS, LADA Superformula AI, Hofer QST, Carmona, and Nalasami. Root mean square absolute error, median absolute error, a percentage of eyes with prediction error within plus minus 0.5 were the main outcome measures. Hill-RBF achieved the lowest root mean square absolute error, Pearl DGS second lowest, and Hofer QST the third lowest. Hill-RBF achieved also the lowest medium absolute error, LADA superformula the second lowest, and Kane the third lowest. The highest percentage of patients with prediction error of percentage of eyes with prediction error within plus minus 0.5 was yielded by Hill-RBF, followed by LADA superformula and Hofer QST. As conclusion, the Hill-RBF formula provided highly accurate outcomes in medium-long eyes, and all studied AI-based formulas yielded good results in IOL power calculation. Last slide. Winston Churchill, Prime Minister of United Kingdom and also Nobel Prize winner, used to say, a good speech should be like a woman's skirt, long enough to cover the subject and short enough to create interest. I have covered the subject, hoping I create an interest. Thank you for your attention.
Any questions? No. Okay. All right. Thank you, Dr. Victor. So next we have Dr. Bartos. Is he here? Okay. And he'll be presenting on ultra-wide-field retinal optical coherence tomography and angio-OCT using add-on lens.
Okay, good afternoon. And I will start with a simple question whether we really need a wider perspective. Maybe not. So here we have the macula of retinal detachment, and we don't know anything about the periphery. Once we have an image like that and we see a giant retinal tear, it can change our approach. We can go for vitrectomy, not for scleral backing, for instance. And here is a typical central serous retinopathy image. It's a kind of straightforward diagnosis. And this image looks pretty the same. We also have this triangular fashion of subretinal fluid, but once we look at the color fundus photo, we'll, I think, agree that we have a choroidal tumor. So the ultra-wide visualization really matters. And I think that the main advantage of ultra-wide field retinal imaging is diabetic retinopathy, because we are not using angio-OCT in place of photographic grading, even if non-perfusion correlates well with DR severity, because this correlation doesn't mean that we can reliably use angio-OCT for clinical decision making. And the main problem is the field of view that is too small. So I do hope that, and no, I do believe, I would say, that reliable ultra-wide field OCT angiography has the potential to change the way we grade PDR, in the same way OCT itself has changed DME grading. And here we have add-on UVF lens for Revo OCT devices. This is a cost-effective solution. And a few clinical cases. We have branch retinal vein occlusion, 6x6, 15x15, and 21x21 millimeters. A scan of area, and we see that the wider the scan is, the more information from the periphery we can get, and we can really visualize the extent of non-perfusion. Proliferative diabetic retinopathy, if we have a 6x6 regular scan, there's really nothing special about that. We can see the capillary dropout, and that's it, but we cannot make a clinical decision. Once we have ultra-wide field view, we can go for treatment. We can just perform laser treatment. So this is a kind of perfect tool for screening. Another case of proliferative diabetic retinopathy, we have this thick membrane that is spread across the macula, and we can just visualize it at a single, and in a one single scan. Central retinal vein occlusion, We can also visualize nicely peripheral non-perfusion. And high myopia, this is a full range mode, which means that we are using 2/2 of Fourier transform, so we can really accommodate the entire posterior staphyloma in one single scan. And when we have 10 millimeters long regular scans, there is nothing really special about it. But once we have ultra-wide field view, we can quite nicely see the dome-shaped macula due to high myopia. And here, owing to having ultra-wide field imaging, we can see the choroidal tumor. We will not miss it on regular screening. And we can also use it pre-op. We can visualize all the attachment of the vitreous to the retina. If you have a patient like that during the follow-up visit, we don't know whether we have a residual fluid or this is a redetachment of the retina. With ultra-wide field scan, we are safe. This is just a residual fluid. And here we have just an atrophy. If we are going wider, we'll see the fluid, and we can just also perform or create the thickness map and delineate the margin of the fluid. And here we have the angio-OCT. I was really surprised because I didn't expect during the vitrectomy that there is so profound ischemia. Then I would go for extensive laser. And the two last examples, this is a mosaic of 130-degree healthy individual. It's equal to 210-degree internal field of view like Optos devices express angles. And this is Il's disease with non-ischemia and some irregularity of the capillary vessels. And is it easy to use it? You can assess it on your own. It's a real-time video. It just takes a couple of seconds, and that's it. So, ultra-wide field OCT retinal imaging will give us or gives us a wider clinical perspective. And with continuing development of UVF technology, we can expect increased accuracy in dealing with peripheral retinal lesions. So this technique is valuable in the diagnosis, management, and treatment of patients with various retinal diseases. And finally, this is a kind of perfect tool for pre-op and post-op assessment and documentation of VR surgery. So thank you very much for your attention. I think everything is clear.
I have a question, actually.
Okay.
Can you comment on how much this lens costs and how it compares to, say, like the commercial wide field OCTAs, like the Intel?
Well, as far as I know, I'm not a company guy, but I think it's like 2,000 euros or something like that. I'm just guessing, but it's not a lot. It's not a lot. But you need a device, obviously. So you have to buy a device and then the lens. Right. So you cannot attach this lens to any devices. This device, Revo FC, is by Optical Technology from Poland. So, but it's a kind of cost-effective solution. And just to make this technology really widely used, we need cost-effective solutions. Because if you have for $1 million device, it's great. Maybe you will buy it for Texas, for your university. But then regular people will not use it. So will not change the grading of, let's say, DR. So we need a technique that will be commonly used.
Thank you.
Thank you.
Okay. Next we have is Dr. Dan Li Shi here. No? Okay. So then she has two presentations, but you move on to Dr. Marta Satori, right? She will be presenting on outcomes and improvements in tomographical analysis in corneas that underwent asymmetrical intracorneal ring segments for the management of keratoconus.
detection. Dear ladies and gentlemen, my name is Derming Wang. It's my great honor to share the chance here. I come from Zhengshan Ophthalmic Center, Sun Yat-sen University, Guangzhou, China. Today I'm going to discuss with you about development and clinical deployment of a smartphone-based visual field deep learning system for glaucoma detection. I don't have any financial disclosure. As we know, glaucoma is the leading cause of irreversible blindness worldwide. Glaucoma screening is hindered by the lack of cost-effective tools and a high misdiagnosis rate. These challenges delay early detection and treatment, highlighting the need for an accessible and accurate solution. There is a global shortage of glaucoma specialists, making expert interpretation of visual fields inaccessible for many patients. Interpreting visual field results has a steep learning curve, leading to many cases of early glaucoma being missed. General ophthalmologists and non-specialists have limited ability to interpret visual fields, further exacerbating the challenges of early detection. This study introduces iGlaucoma, a smartphone-based deep learning system designed to automatically analyze home-free visual field reports. It aims to enhance screening efficiency, reduce the burden on specialists, and facilitate early diagnosis and intervention. The study was conducted in two phases. Phase 1 involved training deep learning models for visual field classification, while Phase 2 focused on developing and validating the smartphone application in real-world clinical settings. The deep learning algorithm was trained using key visual field parameters, including PDP, ND, and NDP, to optimize glaucoma classification performance. The combination of multiple features improved diagnostic accuracy. In the test set, iGlaucoma achieved an AUC value of 0.873, significantly outperforming 6 ophthalmologists, demonstrating its potential clinical value in glaucoma screening. The heat maps generated by the model illustrate the visual field characteristics of glaucoma and non-glaucoma patients. Misclassification analysis highlights false positives caused by cataracts or other ocular diseases and false negatives in early-stage glaucoma cases. iGlaucoma offers 3 key advantages. Firstly, it's one of the first smartphone-based deep learning systems for glaucoma detection from home-free visual fields, outperforming general ophthalmologists. Additionally, it operates 5 times faster than general ophthalmologists, making it a promising tool for primary eye care. Last but not least, iGlaucoma supports both iOS and Android systems. Future integration with VR technique could enable smart visual field testing and diagnosis. Our study has been published in the top international journal, NPJ Digital Medicine, which currently has an impact factor of 12.4. We are deeply grateful to our research collaborators for their support in providing data, technical assistance, and guidance. Thanks to all the members of our research team for their companionship and support. That's all. Thank you for your listening.
All right, I think next up is Dr. Mata.
Dear ladies and gentlemen,
Let's, okay, let's just, the stage is yours.
So good afternoon, everyone. I'm very honored to be here in such a beautiful country, in such a huge conference. And I'd like to show our data in tomographic analysis in asymmetric ring segments for keratoconus. It was carried out in São Paulo, Brazil, where I came from. Those are my disclosure. So our data was a serial cases that we saw prospectively, 40 eyes of 28 patients, 14 men. The mean age was 32. We implanted Kera ring asymmetric rings using femtosecond laser LDV-Z8. So those are the asymmetric rings that we used. And as a mnemonic way to understand those rings, do you have a pointer? Okay, yes. So this part is thicker, like a sideburns, and we use in this kind of cone. And those are thicker inferiorly, and you use in those kind of cones. The superiorly upper than 3.5 cylinder, and inferiorly 3.5 cylinder. And those we call the mustache. It is 180 degree long, the arc, and it's thicker right here, and thicker at the tip of the rings, and we use in those kinds of cone. Let's see the first case, a 34-year-old male with those refraction, right and left eye, and we decided to put a sideburns in right eye and goatee in the left eye. And here they are. And look what happened. The astigmatism from 6 came to 1, and the Kmax from 62 to 51. And here the differential map. We can see that the difference is the most where the ring is thicker. The same with the left eye. In another case, a 22-year-old cooker boy that had one eye indicated PKP, and the second eye, the left eye, had this refraction, and those images. And we implanted at 100 and mustache, 180 degree of arc ring. And what happened? See, quite difference in the differential map of topographic, and see his refraction. And the OCT would also show us, this is pre-operative, the thinnest part of the cornea, and then 1 year post-op, we can see the thinnest part is going toward the center of the cornea, and this is the image of the epithelium map. And we can measure the rings, like 200.5 here and 100.5 here. So we can see that the bulging of the cornea anteriorly can happens. And those images we can see the higher order aberrature coma changing from almost 2 to 0.6, and this is the sphericity changing, and the best index that we saw was the toric anterior elevation map that we can see here, how different it is. In a mustache kind of ring, goatee, look how different it is, and sideburns, here and here. So our results after 1 year of a follow-up shows that 100% gain 2 lines or more, refraction improved a lot, and sideburns especially decreasing the cylinder, Topographic also improved a lot, and anterior thoracic elevation map was the index that showed the most difference, especially in the long arc rings. OCT pachymetry was significantly greater than the Galilei pachymetry. So, in conclusion, asymmetric rings are safe and effective in increasing vision. So the long arc, sideburns, and goatee decrease Kmax and cylinder the most. And the mustache kind of ring, although is the one that the sphericity changed the least, the location of the pachymetry and the Kmax came towards the central cornea. The nomenclature was interesting to understand the mechanism of action of each ring, and the anterior thoracic elevation evaluation was the best index to see what happened to these asymmetrical rings. As far as we know, Galilei's device is the only device that has this differential map. Thank you very much for your attention. Any question?
Yeah, is there any question? No? Okay, thank you. Thank you,
I think
Dr. Martha.
everybody's from retina and not from the anterior segment, but anyway,
Right.
those are images. Thank you very much.
Yeah. So I guess, yeah, I think
That
we can
concludes
just, yeah.
our session. We're a little early, so thank you very much to all of our speakers.